It's Becky Sanders, and I want to welcome you to today's virtual office hours. Luke Worley and I are going to be talking about how telehealth is access when we talk about healthcare. So let's get started. If you've attended any of the Upper Midwest Telehealth Resource Center events before, you know that we're part of a national consortium of telehealth resource centers. We cover the states of Illinois, Indiana, Michigan, and Ohio, but we're only one of 12 regional telehealth resource centers. So you can see on the map that every state in the United States is covered. The Pacific Basin Telehealth Resource Center will tell you that they cover a physical area that is larger than the contiguous 48 states. They cover Guam, American Samoa, Federated States of Micronesia, so a lot of places. We also have two national telehealth resource centers. The first one is the Center for Connected Health Policy, which is our policy resource center, and then we also have the center, or the TTAC, which is the Telehealth Technical Assistance and Resource Center. So altogether, the 14 of us are the National Consortium of Telehealth Resource Centers, and we do have a national website. You see that link there on the slide. We have monthly webinars that are hosted in rotation by each different regional or national telehealth resource center. And there's some national resources. There's also an interactive map on the national website that can get you to any of the different regional or national centers. So here at the Upper Midwest Telehealth Resource Center, I like to say that I'm a virtual librarian. A lot of what we do when we get calls or emails is direct people to electronic resources on our website or provide connections with other programs for best practices. And then we do a lot of presentations like what we're doing today and stay up on policies in our 4 states. All right, so the basic foundation of any telehealth program is broadband. If you don't have broadband access, then over time your program is going to dissolve because it doesn't have a proper foundation. Some broadband recommendations from healthit.gov. For a single physician practice, they recommend 4 megabits per second. For a small physician practice or a nursing home or a rural health clinic, they recommend 10 megabits per second. And for a hospital, they recommend 100 megabits per second of internet access. Especially with COVID-19, we've heard a lot more again about the digital divide. So I wanted to make you guys aware of some federal programs that are available for healthcare organizations to take advantage of if you don't have adequate broadband access or if you can't afford adequate broadband access at your health center site. So the first two are from the United States Department of Agriculture. They have a USDA Community Facilities Program. This program is for rural areas with no more than 20,000 residents. The good news is this funding can be used for just about anything. For hospitals, medical clinics, nursing homes, purchasing equipment, paying related project expenses. The second program from USDA is a little more difficult to get because it's based on some objective scoring and there is match money. There's a 15% match that is a requirement, and the higher objective score that you get is based on the percentage of national school lunches in your areas where you're going to be providing services. So they look at the NSLP, or National School Lunch percentages, for the individual schools or for the school corporation where you're going to be providing services. This program is strictly for capital assets and training on capital assets, so it's a little bit more restrictive. Then there's 2 programs I wanted to highlight under the Federal Communications Commission. They're both administered by USAC, or the Universal Service Administrative Company. The first is the Rural Healthcare Program. It is currently funded at $400 million per year. And under that Rural Healthcare Program, there's two programs. The Telecommunications Program, which is based on an urban-rural differential. So if you bought telecommunications services in Indianapolis, Indiana, and they cost $1,500 a month, or I'm sorry, they cost $500 a month. And then in, let me see, Clinton, Indiana, they cost $1,500 a month. Then there's a differential of $1,000 a month. So if you are in an organization from Clinton, Indiana, you applied to this program, you would get $1,000 a month credited to you and paid from the program to your telecommunications vendor to make the your price for that service the same as a healthcare entity in the city of Indianapolis. The other program, which IRHA, our parent company, has an Indiana Telehealth Network program, has a consortium under the Healthcare Connect Fund. And this program operates on RFPs and competitive bidding cycles, but it brings your cost down to 65% of the eligible cost. So again, the program pays that difference between 65% and 100% for construction of fiber optics for broadband services, and also for ongoing monthly services. So here's just some highlights about those two programs. And we, as we are recording today's session, we will post the slides as well as the recording on the archive webinar section of our umtrc.org website. All right, there's two more FCC programs that I wanted to mention. Right now with COVID-19, in the CARES Act that was passed at the end of March of 2020, is the COVID-19 Telehealth Program. And this is for healthcare entities to help connect their patients, to allow their patients to be at home but still take advantage of telehealth services. So purchasing for connected care equipment, necessary information services and devices. The devices have to be integral to patient care. They have to be connected devices, i.e. Broadband devices, so they have to connect via Bluetooth or wireless Wi-Fi connectivity, those types of things. So that is available. And then this final one I wanted to mention is the Connected Care Pilot Program. The final rules for this program were adopted at the end of March of this year, but I haven't seen anything yet that it's actually open and operating. So that's something to keep an eye out for. This Connected Care Pilot Program is designed to cover the construction costs for that last mile. So from a large healthcare entity or even a rural health clinic in the middle of town to an individual's home. So to make sure that they have adequate broadband services in their home to be able to access the services from their provider. All right. One final program from the FCC that I do want to mention, and now this, we're kind of switching perspective here. This is for consumers. So if you have consumers in your market area as a healthcare provider that do not have adequate broadband access at their home, this is an option for them. This is called the Lifeline Program. To be eligible for this program, a consumer has to have either income that's 135% or less of the federal poverty level, or they have to be enrolled in Medicaid or SNAP or another federal program like Social Security. Benefits for this program, they can get discounts on either their landline telephone service, a mobile cell phone service, or broadband internet access at their home. So there's the link for that. All right, at this point, I'm going to pass everything over to Luke.
All right, thanks, Becky. I'm going to be a good public health professional and be the one that talks about all of the barriers, but I'm going to try and at the end of it, maybe offer a little bit of insight from the literature review that I've been doing over the past week or so. And then I will also give Becky a list of my citations so that I can get those out to everybody if they're interested in looking up information that's more germane to some of these other topics. So there are some, all of us are on this call because, we're familiar with telehealth in some capacity, and, we're advocates in some capacity, or end users, or we have some kind of familiarity with it, but there are some barriers to widespread telehealth adoption at pretty much every level. So one of the big ones that's kind of hard to quantify is technology literacy. Becky's talked about the access level and the disparity between urban, suburban, and micropolitan and rural communities in terms of just being able to get connectivity. But one of the things that we do have to also keep in mind is that access to smart devices that can actually connect on an LTE network or a Bluetooth or connect to Wi-Fi tend to be stratified across class, geography, and age groups. So that's definitely one thing to keep in mind when you're thinking about access. Over the course of the public health emergency, one of the things that we would get calls for frantically from physicians who were primarily serving Medicare populations is that, how am I going to do telehealth when, 75% of my population has flip phones? So that's one thing to keep in mind as well. And we talked about stable connection and speed. And then finally, one of the institutional and social barriers that you have to consider is, how much do people trust technology, right? Do they think that it's a good substitute or supplemental tool to in-person care? And if not, then that might be a barrier that you have to overcome. One of the other barriers that we see across hospital systems at pretty much every geographic community is interoperability of healthcare systems as a whole, whether that's integration of different electronic medical records or other institutional barriers there. And then I did talk about geography very briefly. In rural communities, obviously, technology access, interoperability, broadband adoption, broadband access, all these other things are a little bit trickier. But in highly urban communities, especially persistently poor communities and urban communities, sometimes originating site rules can still be tricky there, even though you would think that they have access to everything just based on being located in a major metropolitan area. So, we tend to think of geography as a purely rural issue, but we're starting to see that some of these institutional and social barriers exist for people who live in the middle of gigantic urban centers as well. One of the big things I think people cite when they're talking about adopting a telemedicine program is, how do I make this sustainable? And I think this is due somewhat in part to the fact that at its core, I think telehealth is billed as a cost saver rather than a revenue generator. And so I think as far as the culture of telemedicine and telehealth goes, we need to start talking about how do we overcome that perception, right? One of the other things is obviously institutional buy-in. If you're a large hospital system, that's one thing. If you're a small, 1 to 4 physician clinic, or a federally qualified health center or something along those lines, you have to get providers themselves to be comfortable and trusting of the technology as a good supplement to their in-person care, right? But the biggest thing that we see, and this is going to be the thing that I think I come back to after the end of all of these barriers, is adequate training to integrate telehealth and telemedicine into your workflow is going to be the #1 issue. Because even if you have a bunch of institutional buy-in and you have a bunch of people who say, this seems like a really good idea, I love all of this idea, but how do I actually make it work? Then you have a problem. Let's see if I can move on here. There we go. One of the things that I don't think we generally tend to think about, other than the actual physical devices and where people live and that kind of thing, is that there are a lot of socioeconomic and cultural determinants of health that affect telehealth access as well. So one of the things that if you're going to be instituting telehealth as a major service arm, is that you have to make sure that you're still being culturally competent, right? If you're dealing with any kind of widespread, diverse populations, like you've got to be able to serve their needs according to what they need as you would in person. And just being behind a screen, even though there's a separation and a remove, we have to make sure that we're using culturally competent language. We're not misgendering people. We're trying to make sure that we make this kind of thing accessible for people with disabilities, that we ensure that all of our communication is crisp and clear and provided in a culturally competent and responsible manner. So obviously a lot of things go into that. Level of education sometimes generates some issues from a telehealth perspective, because if you're operating in person, there are certain things that you can kind of point to and gesticulate and gesture, and there's all these other unwritten and unspoken communications that you can do to overcome some health literacy barriers. Via telehealth and telemedicine, sometimes that's not as easy. So you need to be able to anticipate those and overcome them. Obviously with class, we're talking about access to devices, access to safe and affordable housing. We're talking about all these different issues that you might want to address as a system before, implementing telehealth as a major service arm. Language barriers, right? Being able to ensure that there's a translator of some kind if necessary. If you have consent forms, that those have been, properly vetted and translated, that kind of thing. And then finally, the last thing, of course, is if you're not already, making sure that underinsured or uninsured populations have those needs met, so that you can alleviate some of those other barriers to care, like the geography or transportation component. And then finally, I think that this is one of the subtle ones that not many people talk about. I think the biggest social and institutional barrier from a widespread comfort level among C-suites and top academics across the country is that the research base regarding the efficacy of telehealth and the evaluation of telehealth kind of as a whole on a national, state, metropolitan, municipal, even individual system level is just not as deep as you would like it to be. So that sometimes, because there isn't as much research out there, sometimes it creates discrepancies in the literature, because you'll have one study that says telehealth costs savings are amazing, right? It's in this particular population over this many years, it saved this population $1,500 per ER visit, or this system $1,500 per patient. And then sometimes you'll have another one that says, yeah, but and then kind of contradicts it. And I think part of it is just that we have to be really vocal about, okay, it's good to have telehealth adoption and funding mechanisms, but we also need telehealth research so that we can support the fact that what we're doing is efficient. And then also for our own purposes to figure out what telehealth is really good at and what telehealth is not particularly best suited for. I think that that's one of the biggest things. I saw that there was a question in the chat. I will get to that in just a moment. So barriers to telehealth access from a policy standpoint, we're not a lobby organization, but we're doing everything we can to try to overcome and advocate for widespread policy change, sort of to keep the momentum going that the COVID-19 pandemic has created. So obviously reimbursement is the biggest one. If you're not going to get paid at a comparable rate, or you're not going to get paid at all, it's hard to sell adopting telehealth. And then finally, originating site designation kind of falls into this, where right now patients can be seen via telehealth and telemedicine in their homes, which is great. And some other state Medicaid programs have instituted this, but until we get it on a federal level, it's going to be hard, I think, for other states to follow suit, because most tend to just follow the practices of CMS and Medicare. Malpractice coverage has sometimes been an issue where there's not clear language on telehealth in terms of policies for covering medical malpractice. And this kind of is tied into licensing and credentialing. Not every state has has a interstate medical licensure compact, and sometimes even those don't have language specific to telehealth. And so practicing across state lines, while even we as a regional telehealth resource center, we would love, the ideal situation for a telehealth visit or a telemedicine encounter is to have a provider who is at least geographically proximal, who gets all of those cultural competencies, who understands their local population, that kind of thing. But sometimes that's not always available. So being able to get licensed and credentialed across state lines is also something big. Obviously, HIPAA and security is a big deal. Whenever you're using any kind of platform and you're relying on some kind of third-party software, unless you have your own coders, one of the things that you have to ask is this going to be HIPAA compliant? Is this going to be secure? And then the last one is being able to prescribe. And then what constitutes an ongoing patient relationship. Now that we're in the middle of a pandemic, those rules have been relaxed a little bit. You can see first-time patients via telehealth, and so now you can prescribe, but is that going to go forward? So those are all the things that we're up against, but it's not all bad. Obviously, telehealth adoption has increased dramatically, even in the past just decade. As of 2017, the American Hospital Association estimates that over 3/4 of all hospitals have either fully or partially implemented telehealth as a service arm. So that's encouraging. And I would assume that that number has actually continued to grow even over the last 3 years. And so as a result of this widespread adoption, there have been some research dollars that have helped contribute to the literature base. And so what I was able to find is that as of right now, telehealth, and especially direct to consumer telehealth, has increased patient access dramatically, especially during the COVID-19 epidemic, and it's provided a massive relief for a lot of emergency departments, ICUs, that kind of thing. And that, I think, over and over and over again gets emphasized in the literature, that telehealth as a point of entry, as a point of access, is at its best when it diverts a patient who would otherwise walk into the emergency room with otherwise very, very easily identifiable and treatable conditions. And of course, it's a major cost to the hospital to keep them there, and it's a major cost to the patient to show up there and present, even with acute conditions, but could be potentially seen in a different location or seen via telemedicine encounter. And a lot of the literature is pretty consistent that a telemedicine visit that doesn't need a referral to the emergency room or to the hospital costs about 5% for both the facility and the patient of what an emergency department visit would cost otherwise. So those cost savings are great. And even on sort of outpatient specialists or just outpatient primary care, and definitely for mental health care, cost savings sort of range from sometimes only about $20 to about $150 per patient. So that can add up over time, but because the literature base is rather shallow at this particular point, it's hard to pin down a definitive number in terms of what it saves a patient to engage in any one particular modality via telehealth. And then mental health care coordination, I think, is the other one apart from emergency department. Being able to simply get on a video conference with your psychologist, which you may not have in your county, a psychiatrist who may be overburdened in a gigantic metropolitan area. It's increased access to mental and behavioral health care by orders of magnitude. So that's definitely something encouraging as well. We're also starting to see a lot of progress in managing chronic conditions, including diabetes self-management training and that kind of thing. But finally, the one that an overwhelming number of acute care and internists use is store and forward technology to be able to actually grab images, send them off to a consult, have it be looked at, and then sent back to them. And while reimbursement is limited, a huge number of providers use store and forward all the time. So finally, the thing that I need to come back to is funding mechanisms for research. But ultimately, the thing that I think is going to help increase your patient's level of access to telehealth is to really make sure that you have a plan to address that workflow concern. You know, what, like have a script. Like, what does it actually look like from the moment that patient initiates that telehealth encounter? What are the questions that you ask? How do you obtain consent? How are you documenting it? And you know, what is your like actual clinical protocol from this time to this time, whether that's, you know, 12 minutes for this and 3 minutes for that 15-minute visit. I mean, really sketch it out so where it becomes routinized and it can be trained and replicated. Because I think that is like the biggest one, or the biggest barrier on a person-to-person basis is, this seems really good, but oh my gosh, I can't do in-person care and telehealth at the same time because, you know, it's just too much of a burden for my staff. So making sure that we address that workflow concern right off the bat is definitely, I think, the biggest concern. Now, Becky, did you get a chance to view those questions there? I can't see.
Hang on a second. I will get to those. I didn't want to move the mouse. Okay.
Here we go.
Yeah, there's some good questions in here. Okay, so 2 questions. CMS has been sending us in circles. Yeah. How can a nonprofit qualify to bill Medicare and private payers as a site or entity? Okay, so this is some deep questions we're not going to be able to cover today. I think Autumn, if she didn't, Autumn, please use the chat to put my email and Luke's email in there, and please, whoever sent this in, send us an email, because yeah, we need to follow up individually. As far as qualifying to bill Medicare and private payers and all that stuff, it depends on what state you're in, if you're billing Medicare, if you're billing private payer, if you're billing Medicaid, and each payer is going to be a little bit different. And you'll have to know your patient's insurance information to know if you can bill patient education for smoking cessation or suicide prevention. And then, can you speak to CMS insurance coverage in Indiana? In established practice, a self-service kiosk in a grocery store? Yeah, that's really beyond our scope today as well. Dave, if you would send us an email, we can talk more about that. Again, so CMS insurance, you're talking Medicare with the waivers in place. The patient doesn't have to be at a clinical site and they don't have to be in a rural area. So that technically should be true. But then there's still privacy and security concerns. Lot of stuff to talk about in that. Let's see what else. I think that's it for today. All right. Any other questions? And you guys can unmute yourselves and talk too. Go ahead and stop the screen share. All right, well, we are past our time for today, but thank you for joining us. And you'll be hearing from Autumn with an email when we get everything up on the website. And I think that's it. Everyone have a great day.